Hello everyone, welcome to Medicine with Faizan. Today we are going to discuss heart blocks and how they appear on ECG. Just to quickly review, the categories of AV block include first degree, where all the P waves conduct. It just takes a little bit longer. I must mention here that first degree AV block is a misnomer because it's not really a block, as the P waves are conducting through the AV node to ventricles. It's just that the impulses get delayed in the AV node. It's a benign finding and can well be seen in healthy individuals like athletes. That's why some electrocardiophysiologists prefer the term delayed AV conduction for first-degree heart block. Now, recall that the normal PR interval should be 120 to 200 milliseconds. So anything longer than 200 milliseconds means that first-degree AV block is present. Third-degree AV block means that none of the P waves conduct, and we'll be talking about in the last section of this video. Second-degree AV block is a condition where some of the P waves fail to conduct, but some get through. Now let's start with first-degree AV block. We have this ECG here, and you can see it is fairly regular. The QRS look pretty wide apart. If you count the rate, here's one that lands on a heavy line. 300, 150, 175, 60. So we're talking about 50 beats per minute. When we look for P waves, we do see that there is a P wave in front of every QRS complex. Now what's the PR interval? Well, it depends on where the P wave starts. Look for the point where it leaves the baseline, and then the end of the PR interval is where the QRS begins. I just want to show you that this ECG happens to have a fair amount of low-level noise, and these little jiggles here are the noise artifacts that I'm talking about. So the question is, where does a QRS start? Does it start with this little bump, or does it not? If you look at this QRS complex, it seems to have a little bump. But there is almost like a double bump, and if you look at this first QRS complex, there's no bump. So when you're trying to decide exactly where the QRS starts, if you only have one lead to look at multiple QRS complexes. The QRS really does start with the first upward deflection, that this first bump doesn't count. So if we say the QRS starts with the upward deflection, that would be about here. There are 4 small boxes on this side of the heavy line. There are 4 small boxes on that side of the heavy line. So if there are 8 small boxes times 40 milliseconds, each gives you 320 milliseconds, and that's the PR interval. It's clearly greater than 200, so we can diagnose it as first-degree AV block. If it's hard for you to count small boxes at this point, it's certainly a bit easier to take calipers to this tracing, and you can place the one tip of the caliper on the beginning of the P wave, the other end on the end of the QRS complex, and when you pick up the caliper and place it on a heavy line, you can sure enough count 8 small boxes, and that gives you 320 milliseconds. So indeed, first-degree AV block means the PR interval is greater than 200, but you see you still have one-to-one conduction of each of these QRS complexes. Let's move on to second-degree heart block. As you can see, the classification is a little bit complicated because there are different types of second-degree AV block. There's type 1, type 2, and there's high grade, which a lot of people don't know. Okay, let's have a quick review of the physiology of the AV node. Remember that the AV nodal cells fire because of calcium currents that go into the cells. So the upstroke of the action potential is a little slurred compared with his Purkinje system, where the action potential is much sharper and there's a little bit more of a plateau phase. So these two types of cells behave differently. In the AV node, the cells basically delay the signal as it passes that signal down towards the his Purkinje system. If the atrial rate is too fast, what'll happen is the AV node will fail to pass the signals down. You'll get delaying of conduction and eventually failure of conduction. This delay, or failure of conduction, results in prolongation of the time it takes for the signal to get through. So the PR gets longer. If the PR gets longer, it usually means there's delayed conduction within the AV node. On the other hand, the his Purkinje system, being sodium dependent and having a very sharp upstroke, behaves more in an all or none fashion. In other words, those cells either conduct it or they don't. So what happens if you have failure of conduction below the AV node? You'll have AV block without any prolongation in the PR. So the PR is constant in conditions that result in AV block below the AV node, and this physiological distinction between these two cells is responsible for different behaviors labeled as type 1 and type 2 second-degree heart blocks. Clinically, the level of the AV block makes a difference as their management is different. But for now, let me just clarify what type 1 and type 2 second-degree AV block look like on ECG. Let's start with this example. At first glance, when you look at the far est, you see the QRS complexes appear to be fairly regular. If you count the rate, you'll find that it's going at about 50 beats per minute. In front of each QRS complex, there does appear to be a pretty clear P wave. It's up in lead 1, it's up in AVF. So the rhythm is sinus bradycardia. Now let's take a look at the PR interval. The PR interval starts just before this heavy line. The QRS complex starts right at this heavy line. So the PR interval here is around 400 milliseconds, twice the upper limits of normal for a PR interval. When you look across, you can see that the PR interval looks pretty fixed. Or does it? If you look closely, you can see this is on this side of the center part, so this is getting a little bit longer. And if you look at this one, it's even longer still. So somehow the AV node is starting to delay the signal. It's taking longer and longer to get down the AV node. What happens is that there's no QRS complex following this P wave. So this is an example of AV block. The atrium fired, but there's no conduction to the ventricles. So you have AV block now. Is it a second or third degree? Well, clearly it's not just first degree because one of the P waves failed to conduct. It's obviously not third degree or complete heart block because most of the P waves do seem to get through. So this is second degree AV block. Now the fact that the PR is getting longer tells you that delay is most likely occurring in the AV node. Since there is prolongation of the PR interval, you can make the diagnosis of type 1. With type 1, what happens is the PR gets longer and longer before the beat finally blocks. Let me give you a more typical example of type 1 second degree AV block. Okay, here's an example of type 1 second degree AV block. Remember, in type 1 the PR interval gets longer before a P wave fails to conduct. Now where do you even start with this ECG? Well, I think it's important to first look at the far est. What you see here are 2 beats. Then there's a little bit of a longer interval, and then you see 1, 2, 3 beats, and then a longer interval and another 1, 2, 3 beats, and then a longer interval. You'll start to wonder if there's a pattern here, a pattern of irregularity. Yes, it's irregular, but what you have is a group of QRS complexes, and then a pause. Then here's another group and a pause, and here's another group and a pause, and then it keeps on going. So this is actually known as group beating, and group beating is pretty characteristic of AV block. Now, if we just concentrate on one of these groups, let's start to pick this apart. In front of this first QRS complex, you do see a P wave and the PR interval looks to be a little bit on the longer side, like maybe 210 or 220 milliseconds. Now let's see, are these P to P intervals regular? In other words, do we have just a sinus rhythm? Well, let's take the next P wave, and if you want to make it easier, you can take your calipers, bring them down and put them on top of the beginning of the P wave, resize them, and then if you march these calipers out, you can see that the P to P interval is really quite regular, so the P's are marching on through. The sinus node is firing at a regular rate. If we try to figure out what rate that is, we put it on a heavy line and then count off 300, 150, 175. So it's about 78 beats per minute. So we have a sinus rhythm at 78 beats per minute. But what's happening is the PR of the second beat is longer than the first beat. You can see it visually. And I think the best place to look at PR prolongation is at that PR segment. See that segment after the P wave finishes and before the QRS. Look, that segment is getting longer. And if you measure this PR interval, it comes out to be about 280 milliseconds. Now this PR segment is very long. and this PR interval is close to 360. Now what happens is this P wave occurs on time, because we've already mapped these out, and there's no QRS complex following it. This sign here means that this P wave blocked. It did not get through the AV node, and it leaves you with a pause. This pause resets the AV node, and so the PR interval gets shorter again, but then it gets longer and longer, and finally you get a block again. So we have a pattern here. There's a pattern of 4 P waves to every 3 QRS complexes. This was first described by a guy named Wenckebach. This Wenckebach periodicity would be expressed as 4 to 3. That's the ratio of the P waves compared to the QRS complexes. Now in type 1 second degree AV block, there's always one more P wave than there are QRS complexes. So you can have 4 to 3, you can have 5 to 4, you can even have 3 to 2. There's always one more P wave than there are QRS complexes, otherwise it makes it a different type of second degree AV block. Okay, so how do you make this diagnosis? You see group beating. You see P to P intervals that have to be regular. Remember, the sinus node is just beating at a regular rhythm, so we don't get any premature atrial beats. If P to P interval is variable, that will simply mean that the sinus node is not conducting properly for whatsoever reason. But what we have here is a regular atrial rhythm, which is sinus rhythm, marching along at a regular rate. What happens is the AV node delays the signal progressively, the PR gets longer, and then fails to conduct. Now there is a way that you can check to see if indeed you have classic Wenckebach, and that is the rule of the pause. The pause should always be less than 2 times the previous R to R interval. So if we take our calipers and move them on over and check this R to R interval, well, let's adjust those so that we get the R to R interval exactly. And then, if we move those calipers over and see what's the size of this pause, we can note where the tip of the caliper falls here and then move it on over. If you take the previous R to R interval, that the size of the pause is always less than 2 times the previous R to R interval. So if you measure that over, it comes out to there. The pause is less than 2 times. And that's a rule that you should be able to prove if you want to make the diagnosis of type 1 second degree AV block. Now let's move on to type 2 second degree AV block. What happens in type 2 second degree AV block is you don't get the PR prolongation. The P to P interval is still regular, and so if you map these P waves out, they're perfectly regular, and you have group beating here. You have a group of 2, and then there's a pause on either side, but when you examine the PR interval carefully, especially look at the PR segment, PR interval doesn't change. And then this beat blocks and the PR following the pause is about the same. And then you have a fixed PR here. And then you get a block again. So the PR never really changes. If we get out our calipers and look at the R to R interval, you should be able to see that the R to R interval from here is exactly 2 times the previous R to R interval. So when the pause is exactly 2 times the previous R to R, that tells you that the PR is not changing, and now what you have here is type 2 second degree AV block. Now type 2 second degree AV block suggests that the block is below the AV node in the His bundle and the bundle branches, and sure enough the QRS complex is a bit wide. It's more than 120 milliseconds in duration. So this is a patient who has significant disease below the AV node, and his conduction system is failing in a very characteristic way. Let's move into high degree AV block. High grade AV block is unique and it's defined as second degree AV block but worse than 3 to 2 conduction. In other words, 3 to 2 conduction is the worst you can get for type 1 or type 2. So that's not what this is. What you have is 2 to 1, 3 to 1 or anything higher than that. Here's an example. If you look at this ECG, you can see the QRS look regular through the whole thing. Yes, indeed, the rate is quite slow. It is in the 40s, and when you look in front of each QRS complex, you do see that there's a P wave, but if you look very carefully, midway between these 2 P waves, there's another one. Okay, this is something that you can't miss. Those P waves here are not conducting, so you have this conducts and this blocks, this conducts, this blocks, and every other impulse is blocking. Now you can see them actually very nicely here in lead V1. Now a lot of people will immediately say, well, this is type 2 because it's 2 to 1, and they'd be wrong because 2 to 1 is neither type 1 nor type 2. The reason is you really don't have two PR intervals in a row that you can tell whether the PR is getting longer or shorter. You only have isolated ones. In order to call it type 1, you have to have two PR intervals in a row that you can tell that it's getting longer, or in the case of type 2 second degree AV block, that PR interval doesn't change, and then you get a block beat. So it's either fixed or it's getting longer. But here, you don't have either of those situations because you only have single PR intervals to examine. So you cannot make the diagnosis of either type 1 or type 2. It is in its own category, that is high grade. I'm going to be finishing my discussion of AV node dysfunction with third degree AV block, also known as complete AV block or complete heart block. So what does complete heart block mean? First, let's have a quick review of what we have learnt so far. First degree AV block means all the P waves conduct. It is just that the PR interval is longer than 200 milliseconds. With second degree AV block, some of the P waves fail to conduct, and depending upon if the PR is variable or if it's fixed, it gives you either type 1 or type 2. High grade AV block is either 2 to 1 or 3 to 1 or something along those lines, but some are still conducting because second degree AV block means only some of the P waves block. Now third degree AV block means none of the P waves are able to get through the AV node, and so the ventricles are not getting the signal. Does that mean you have no heartbeat? If you remember my lecture on normal sinus rhythm, you can find the link in description. If the ventricles don't see a heartbeat, then what happens is a lower pacemaker center will take over and start generating impulses. So in the case of sinus node failure, usually the AV node will start to fire and you'll have a junctional escape focus. Junctional means the AV node, it's the junction between the atria and the ventricle. Those escape rhythms are usually from the AV junction in the range of 40, maybe 45 beats per minute. But what happens with AV block is you'll get an escape rhythm and it could be from the low junction. If you recall, the AV node is connected to the His bundle, but there may be an area down in the lower part of the AV node that would be able to take over. So you can sometimes see escape rhythms in the range of 30 to 30 beats per minute coming from the AV junction. If the AV junction is diseased also, then you can have escape rhythms that are arising from the Purkinje systems, from those fibers down in the ventricle, and those usually give rise to very slow escape beats with wide bizarre QRS complexes known as idioventricular escape rhythms. Idioventricular means it's coming from the ventricles, and usually you'll see rates of 25, maybe 30 beats per minute in idioventricular escape. Those are generally very wide-looking escape rhythms. It means the ventricular rhythm will generally be regular because it's coming from some escape focus. The P waves, of course, will be marching on through, and none of them will be getting through to the ventricle. Here's a good example of complete AV block. If you look at this electrocardiogram and scan across, you'll see that the QRS complexes are there, and they look to be fairly regular, although rather slow, right? Let's find a QRS that lands on a heavy line. This one's pretty close. So 300, 150, 100, 75, 60, 50. So we're in the range of like 42 to 44 beats per minute. So the ventricular rate's about 44. And when you look around for P waves, you see P waves, but they seem to be just kind of hanging out here. There's one, and if you scan across, there is another one. And oh, wait a minute. Here's one too, but when you look at this QRS, it looks like there's a P in front of it. Well, does that mean it's a normal sinus rhythm? Well, it looks like there might be a P in front of this one, but if you look across, there's no P here. Well, actually, you can see a little piece of the P that's occurring simultaneously with the QRS complex. So what you have here is an atrial rate that seems to be marching on through, and you have to look at the atrial rate. Here's a P wave, 300, 150, 100, 75. So the atrial rate is 70 beats per minute. If you look at the P waves, they're up in lead 1, and they're up in AVF. So what you're seeing here is a sinus rhythm at a rate of 70 beats per minute, but none of these P waves are getting through to the ventricles. every single one is blocking. As a result, the ventricular rhythm is a very slow escape rhythm at 44 beats per minute. It's perfectly regular. And it's coming from where? From the ventricles? No, because it's narrow. Look at how narrow it is. It looks like a normal QRS complex. So it must be taking the normal route of conduction down the bundle branches and to the ventricles. And so we would consider this a junctional escape because it's narrow. It's normal appearing. And it's at a rate of 44 beats per minute, which is about right for the AV junction. So to summarize, what do we need to say complete heart block is present? We see regular P-to-P intervals, because after all, we're usually dealing with a sinus rhythm of some sort at a rate anywhere between 60 and 100 beats per minute, with upright P waves in lead 1 and AVF. So we have a sinus rhythm, and the P-to-P interval is regular. The R to R intervals should be regular as well, because if you have complete heart block, then you should be dealing with an escape focus of some sort, and that is not influenced by what's going on in the atrium. The two chambers are not talking to each other. You have to make sure there's no relation between the A's and the V's. So even though there may be P's that don't conduct, make sure you don't have some kind of fixed relationship like 2 to 1 or 3 to 1. And finally, this is very important. The atrial rate should be faster than the ventricular rate. If there appears to be no relation between the A's and the V's, but the V rate is faster than the atrial rate, we call that AV dissociation. And that's something we'll discuss when we get into ventricular arrhythmia, like accelerated idioventricular rhythm and ventricular tachycardia. This was quite a lengthy and complex topic, but I am sure with 1 or 2 revisions, you will be good to go. See you in the next lesson.